Today's HIV masterclass, we are discussing post-exposure prophylaxis. And the outline is that we will cover some of the data around epidemiology, not much from our country, but some ideas around how this prophylaxis works. And then we'll talk about how you can manage exposure and then discuss different prophylaxis therapies that are available. So in case you have a network challenge and you are unable to complete this particular webinar with us, I would like to just give you takeaways already, which is the basic thing that post-exposure prophylaxis means taking HIV medicine within 72 hours after a possible exposure. And we use the word possible because sometimes when we cannot confirm, it is always best to provide the treatment or prophylaxis than to delay it. Also to say that PEP should be used only in emergency situations. So ideally, it's not a program, which has to be provided frequently. If you identify high-risk individuals, it's best to consider other HIV prevention options, particularly pre-exposure prophylaxis. And for today, we are not going to be talking about that. I think everyone in the country is talking about pre-exposure prophylaxis. We have even forgotten that there is this important intervention. Also, remember that it must be started within 72 hours or as soon as possible. And with regards to its effectiveness, science can only confirm that you have to take your PEP for 28 days. We do not have any other evidence, to confirm that you can actually take PEP for less than 28 days. So 28 days is still the order of the day, and I hope that you will adhere to that. So just some information. It's very important to know that South Africa has more than 7 million people living with HIV and AIDS. I know that we are exceeding 5 million people who are on ART, so it's a great success. It's important to note that around 6% of South Africans have hepatitis B infection. So when we talk post-exposure prophylaxis, we tend to be a little bit more worried about HIV, and we forget that there's other serious infections, that we need to prevent. I actually just remembered that I was part of a study where we reviewed, the prevalence of hepatitis B amongst health workers. We also checked, the immunity and other things. And we have seen that most health workers at some point were exposed to infectious blood products. But half the time, the worry is always HIV. That's why if you look at health workers, hepatitis B is becoming an issue. And if you look at the second last bullet there, you see that hepatitis B is actually more. Actually, we always say 10 to 100 times more infectious than HIV. Though half the time when you get a needle prick, we always pay attention to HIV and we forget the other infectious viruses, which also have long-term implications, whether it's hepatocellular carcinoma or even liver failure later on. And you see that globally, it's estimated that around 66,000 health workers have been infected with HBV through occupational exposure. So we cannot just talk HIV prevention, we have to talk about HBV and what happens if you are exposed to infectious blood body fluids. So here's just some data around which is reported by CDC, just to give an idea of what usually happens in terms of the chain of events. You see that in the US, approximately 30,000 exposures were reported between 1995 and 2007. 82% of these were actually needle stick injuries, right? And then 79%, being involved in blood or blood products are quite important. You see that most of the time the operating room accounts for a significant number of these exposures, and 72% involve direct care employees. And you see that nurses tend to be more affected, than doctors. But all in all, we are all health workers, and this is something that we really need, to work on. Again, 12% of the source patients, right, tested positive to at least one or more blood-borne viruses, which could be hepatitis B, C, or HIV. And HIV was detected in 4% of source patients. and you can see that the majority of the source patients tend to be actually be more infected with other viruses, not necessarily HIV all the time. So really the message is starting to say beyond HIV, you are at a higher risk of being infected with other viruses, and we need to start to be on the lookout of that. Another thing which is quite important is that of the 1,400 health workers, where the source patient was HIV positive, only 63% took PEP. So you should tell us why sometimes we may not, take PEP as health workers. 40% is a huge number. It has to be taken all the time once, we suspect exposure. And also most of the time it's initiated within 3 hours, I think, which is good. But you can see that the average time of adherence to PEP is 25 days rather than the 28 stipulated days. And remember, this is average. It means some people would actually take PEP for less than 25 days. And from science, like I said, PEP is only effective truly if you take it for the required duration, which is 28 days, right? And you can see that most of us do experience side effects. Actually, as I was reading this, I laughed and I said, yeah, well, I remember my own experience and how I felt at that time, having to take zidovudine, lamivudine, and lopinavir when I was still working at Barberton Hospital. But yep, it seems like health workers experience more side effects really than the general population. And I wonder why that is the case, right? So out of all these cases, 58 were confirmed, to be occupationally acquired HIV infection. So a significant number of people that we are following since I started on this. So out of the 1,400 people, 58 actually became infected, and 150 were sort of possible. So they became infected, but it was not necessarily easy to confirm whether this was occupationally acquired or not. And you see that nurses again carried the highest burden. Obviously, remember we said most of the exposures happen amongst nurses, but again, in terms of now where people become infected, you see that nurses were more affected, but since 1999, in the US, only one case was confirmed. And again, if you look at this, another sort of surveillance report, which I've managed to find, in this instance, almost for all health workers who receive PEE, there was no infection. So what is the message around these numbers? Number one is that these exposures are quite common. When they do happen, we need to be able to respond very quickly and offer appropriate PEP. When you think of PEP, yes, HIV is the disease we are all worried about, but remember there's other infectious viruses which are more infectious than HIV itself. The other key message is that PEP must be taken for at least 28 days. It's possible to become HIV infected, occupationally, but you'll see that since 1999 in the US, only one case really until now has been confirmed. So I think very early on, maybe the regimens were more complex, more side effects, people interrupted. But in today's world, we've got better regimens that are more potent, which we can benefit from. All right. So yeah, so obviously I have a case which I want to discuss, but before that, a message from the WHO based on this data is to say that it's important that the PEP be offered on time. It's important that we are adherent when we are prescribed PEP. The timing is very important, and the level of exposure needs to be assessed. So every time a health worker, has been exposed, we need to understand, is this a low risk incident? Is this a high risk incident, so that we are able to provide appropriate support? But at the heart of it is the issue of adherence, is the issue of starting on time, completing 28 days, and in bold there, beyond just checking for HIV and AIDS, we need to pay attention to other blood-borne viruses that we might end up having. So that is quite key. And just to give you just at a high level, what is the framework? The framework is that, firstly, we need to prevent these exposures. And this requires that every health institution has at least policies, we train ourselves, and there's regular audits to assess that we are adherent to universal standard precautions, around how we handle blood or soiled, materials within the hospitals, how we manage medical waste, which is quite important, and as well, how you handle sharps within your institution. So primary prevention in a light blue there, it is at the heart. What we don't want to do is to always have incidences and be very reactive. So we want to make sure that we prevent the occurrence of these. And remember, every single incident that happens, we have to record. It has to be recorded because it is an occupational exposure, irrespective of who you are within the institution. I know some people, they just want to get PEP without testing. Let's try to follow the protocol. So you must record, you must protect. So as soon as someone reports the exposure, we need to respond and ensure that we're able to provide appropriate post-exposure prophylaxis. And lastly, we have to investigate. All exposures must be investigated with an aim to identify, areas that need to be improved, especially around primary prevention, so that we can prevent more and more health workers becoming exposed. So I'm hoping from here, you are with me. So here's our case scenario for this evening. So now my teaching is done for the evening. Now I want to hear from you. So here's a Dimpo. Dimpo in South Sotho, the D is written as an L. So here's Dimpo, a 26-year-old female who presents with a main complaint of, I don't feel well, right? So if you see a young female coming to you and she says she doesn't feel well, the chat is opened. You may want to start to engage with me. How do you approach a young woman who presents with a chief complaint that I don't feel well? I mean, if someone comes and says, I don't feel well as they come through your consultation room, how would you approach this patient? What questions would you plan to ask? So Franz says, are you on any chronic meds? Okay, yeah. So, because if I'm not feeling well and I'm diabetic, I see Matloli says your last menstrual period. Yeah. In South Africa, we have a guideline that says every woman of childbearing age, we need to ensure that at least a pregnancy test is done. So that is required. Aniki says, I will ask what they mean. Yeah, probably it's important because I don't feel well is a bit broad. So we want to know, what do you mean? Past medical history, Chimbaya, Kabongo there, take further history, gynae history, sexual history. How long have you not feeling well? Good. I like that. Catherine, how is your vaginal discharge? That's quite interesting. Sexual history, Cindy. Okay. Unfortunately, guys, there's like 500 of you or so, so I won't be able to read everything. But at the heart of it, you want to take proper history of this main complaint. Okay, you don't feel well. Tell me more. Tell me more. What do you mean? What does not feeling well mean to you? And then, and I see. Carl, you are saying serial history. Maybe you want to clarify the serial part of it, but I'm following a proper history taking. Okay, when was your last VCT? When? So, John, you think this has to do with HIV? Okay, cool. Let me, Carl, I meant sexual history. Okay, thanks, Carl. Thanks for that. I think I'm seeing it. All right, let's proceed. So yeah, so remember that it's important to maintain confidentiality, all the time. So you want to be careful to ensure that you build that relationship and you try and make sure that Limpo is comfortable because you want to know more. You also want to observe not only what she says, but you also want to observe what she is not saying, but maybe what the non-verbal facial expression, posture, movements, how she's. If someone is busy looking all over the room, maybe she's scared, did she come alone? Does anyone else know she is not feeling well? Can she explain what she is feeling? What makes her say that she is not feeling well? And how long has she not been feeling well. So it's important that as health workers, we remember the principles of making people feel safe, of making people trust us, so that they are able to express themselves. Because as soon as there is fear, we might not actually get to know exactly why Dimpo, is here today. After you inquire more, she reveals that she is sad and distraught. She tells you that she has a sore vagina and she is scared she might be pregnant. All right. So now that I've given you a little bit more, are there any additional screening questions you want to ask? Based on what you have now, she's scared she might be pregnant. She's got a sore vagina. She's sad and distraught. The baby Tabo says last normal menstrual period. So you want to estimate, how far, why, she might be pregnant, but before the LNP, don't you want to know why she thinks she's pregnant? I saw something about 7 days. Let me go to it. Chumani, did you have unprotected sex in the last 7 days? All right, fair enough. Explore sexual. And Cindy, I would really like to hear your voice later, because I want to understand, how do we explore sexual assault in a sensitive manner? Because you can see it's getting a bit, Misha says any sexual abuse. Misha, I wonder how you are going to ask, says Norm, so how are you going to ask that question, any sexual assault? How do we ask that? Luboya, last unprotected sex, okay. Last consensual sexual engagement, last encounter. All right, I see where we are all type of vaginal discharge. All right, okay. Jasper, how long has it been sore? Does she have abdominal pain, discharge? Okay, yeah. So you want to ask further about that, right? So where I want to get to is that there's no correct answer to this question, right? Because you want to inquire so that you can try and figure out, what is happening, right? This would be an appropriate time to assess for physical violence and sexual coercion or abuse. But I have a question, how would you word questions assessing sexual abuse or coercion in a sensitive manner? I also don't necessarily know, but what I want to ask is, is there someone who wants to give it a try? You may raise your hand. I want to hear your voice if it's possible. You may try to type, but I want to get a sense. How do you ask questions about physical violence or sexual coercion? We had a webinar on intimate partner violence not long ago, and I think there was some framework. Anyone who wants to try, you may raise your hand, and I want to hear your live comments on how this can be approached. I see Renee Coleman, phrase it carefully, but familiarize yourself with the concept. Yeah. Maybe Renee, can I give you a chance if you don't mind? I see your hand is up. I just want to hear how your advice. Yes, Renee, you may unmute.
Good evening. Hello.
Yes.
I think it's very important that physicians should become comfortable with a sort of universal screening approach. If we say to our patients, you know what, violence is everywhere, gender-based violence is everywhere, it's around us, it happens in our communities, we need to sort of just ask all our patients whether you are, if you're in a relationship, do you feel safe? Is there anything that we can help you with? Is there anything that we can support you in? So it's a universal sort of approach. It's almost saying to your patient, we ask all our patients this question, men, women, it doesn't depend on your sexuality or anything like that. So I think if physicians, if clinicians and medical practitioners, healthcare workers become more comfortable with that approach, and you will find your phraseology that works for you. But I think it's just, if you're comfortable and you're comfortable asking the questions, then your patient will be comfortable and take you into their confidence to trust you, to tell you the truth. The problem we have, obviously, there's a different lecture for a different day, is mandatory reporting, but that's something that we don't need to discuss now. But I think we need to become comfortable with asking the straight question and not, yeah, that's just my feeling. Thank you, colleagues.
Yes, Rene, I really appreciate that. And I think it comes with getting used to asking these questions as part of your usual history, irrespective of how people present, so that you become comfortable yourself and confident over time, and you are able to ask. Because in this instance, you know, you already suspect it, but I think these are questions we probably need to find ways to integrate in our normal history-taking process and ask, because people do experience violence even if they are not necessarily there for this particular incident. So thanks for that, Renee. Let me hear what Matseke says, and then we will then move on. Yes, Matseke, your hand was up. I don't know if you want to unmute them and we can hear. Thanks.
All right, can you hear me?
Yes, thank you, loud and clear.
Yes, sometimes you can ask the person to say if maybe he or she is actually sexually active. And then if they respond, then you can ask if maybe, is there any other person who has ever forced yourself to you? Yeah, sometimes it might sound sensitive, but also we need to ask questions that they'll be able to be comfortable to answer.
All right. Yeah, thank you. So we it's something that comes with practice, and you have to be comfortable, you know, and learn, you know, your own way of engaging on these sensitive topics. But remember, when we did the topic of intimate partner violence, what we learned there is that the majority of people who experience physical violence or even sexual coercion might not even have any signs, you know. So the asking is quite important. So quite key. I see, Anika, you are saying I'd ask, just want to see it's moving. I'd ask a patient to tell me more about their sexual life, found out if they are able to negotiate safe sex, or they can say no if they don't want to have sex. Yeah, all right. I'll rapport should be built with the patient first before you start asking questions. Maybe one can say, have you ever been intimate with someone you didn't want to? Or have you ever given in to a sexual encounter to someone to avoid being hurt? All right, yeah. So we can learn a lot from what is shared in the chat group. So I'm hoping we are all reading there. Make the patient comfortable. Hope she opens up and she's ready to talk. Yeah, quite key. Ask if they are sexually active and find out if the relationship, or how is the disabled talking here so that I'm not distracted. All right, it's fine. So yeah, so here we are. So the report then further tells you that she was visiting a family member, a male, and a male who was there. She did not really reveal who the person is, but there was a male there who forced himself on her and had sex with her. How do you proceed? How do you proceed? And I know we might have people who work at PHC, at hospitals, in the private sector. You are a private GP. How do you manage a scenario assault? Right, Renee, thanks. We build rapport. We don't start with consultation with these questions. Okay, thank you for that, Renee. Yeah, all right, colleagues, how do you move on from here? Maybe let me, okay. where you work in a space where key services around forensic medicine, are not necessarily available. Renee says, think HIV test, emergency PEP. So maybe this time around, let's use a question. And then I'll ask also Mr. Orapelek to make a comment after, based on how you are going to respond there. There is some options for you to think about. Based on where you are working, what options would be viable? All right. Quite interesting. We have 3 more seconds. We can only open these questions for 30 seconds, right? I would call the female nurse, as we have a multi-team that can assist, psychological. Okay. The minute the client mentions forced sex, she needs to be referred. Yeah, Jabulile, where do you operate? Is it the primary healthcare? Is it the hospital? Every health worker should be able to contain and reassure. Right, interesting. Mandla, I will treat the case. So you work in a setting where you have access to some of the requirements like a kit. Okay, let's then discuss. Mr. Motlauling, here are some of the responses. I don't know if you can see the responses from your side. Would you like to make a comment based on what we see here?
Yes, thank you, Dr. Mawela. Yeah, I've been reading the responses, and I think everyone is actually right. There's no answer, there's no, wrong answer here. It's very important that we take proper history and to probe further of what could have happened to this person before we can make any assumption, or we can even make any examination to the person. So yeah, everyone is correct. Yeah, it's very important, because I see that most of the people are also saying it's important to build rapport, which is very true, that so that the person can be able to open up, to you as a healthcare worker. Thank you. Over.
Great. And Renee, I also like your comment there to say we should care for the patient first, and not be quick, to refer. Forensic needs are never very urgent. So we need to make sure that our patient is stable, whether psychologically, physically, So we have to try and take further history. We have to do an examination. It's important to assess exposure and risks that are involved, to assess eligibility for PEP. The last two, in this instance, I wouldn't like to refer her to a police station of any form. I'm hoping the police would either come to my center where I am, or if I'm referring her to a next level, they should probably come there with the relevant things. But I know the logistics on the ground, because this is a space I've worked for a number of years at Jubilee, the crisis center there. And I know that if they come at the crisis center, sometimes they don't have a case, and if you don't have a case, you don't have a forensic. But these are things that we are continuously working to improve, so that our service is quite person-centered. It's quite person-centered and not necessarily done, for compliance purposes with the legal system, which is quite important as well, but we need to always remember that we are dealing with our patients. So just some few theories, types of exposures, very important, that we can get, needle stick injuries, we can get deep percutaneous sharps injuries, splashes of blood or bloody fluids, into your eyes, mouth, or nose, exposure of intact skin to blood. So if there's a splash to your skin, but then you had a non-intact skin, like a crack or a wound, that would be generally regarded as some level of risk. Sexual exposure in the South African context is quite important, whether it's done vaginal or via rectal penetration. Exposure can also happen through sexual exposure, even if it was not forced. So through consensual intercourse and things like, your best condoms. And we've got, inadvertent exposure, for example, sharing of needles. So at the time when the needles are shared, the people were not necessarily thinking of infections, but unfortunately, as a secondary outcome of that, you find that there is transmission of infectious viruses, accidental injuries. If medical waste are not exposed properly, someone is trying to hold a plastic bag and there's needles, sticking out. Used condoms. Someone says my child was playing with a used condom, because sometimes people just throw these things, everywhere. Human bites, when you are trying to help someone during a vehicle accident, expressed breast milk, where things are not labeled properly, whether it's a pediatric ward, whether it's a early childhood development center. Very, 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 very important to know that if you mix this breast milk and suddenly someone's child is drinking another child's milk, and maybe the mother or the guardian is HIV infected, those kind of things are quite important. Now, when you assess risk, it's also important to know which fluids are regarded as infectious or which fluids are regarded as non-infectious. So blood, intimate fluids, like and other fluids, whether it's your CSF, pleural fluid, these fluids would be regarded as infectious fluid. But this is quite important because as well, tears generally regarded as non-infectious. Saliva, as long as it is not blood stained, sweat, urine, stool. There's always an argument around vomiters. I know of a case where I was called and a patient vomited, on a clinician's face. And there was a big discussion around whether, we need to give prophylaxis or not. So some cases are quite difficult, to sort of assess, but always discuss the fluid. These vomiters, did it have blood? How much blood was there? What type of incident is this, the duration of exposure, but also the source, because if you are able to test the source and you realize that the source is HIV negative, they don't have hepatitis B, they don't have hepatitis C, that would sort of really, allay your fears and sort of help you to think whether these incidents, should be regarded, as low risk. And you can see that your percutaneous kind of exposure is regarded as a super high risk, for transmission, versus if there's exposure via the skin or even, mucous membranes like a splash, right? But obviously things like the viral load of the source, can easily change a mucous membrane exposure to a high risk exposure if the source has a very high viral load of, either of the 2-3 viruses we are talking about. Also, if there's exposure through the skin, what you want to evaluate is whether, the skin at that time was intact or non-intact. Because if it was intact, no sores, no tears, or scars or things like that, then you start to think this is probably a low risk exposure. So the assessment of exposure, the risk of transmission, these are quite important. So who is not eligible, for example, for HIV, PEP? Someone, if the exposed person is known to be HIV positive or hepatitis B positive, obviously, if the person is already infected, there's no point in providing PEP. If the source of the infectious material has been confirmed to be tested, hepatitis B negative, or even HIV negative, if exposure to bodily fluids that do not pose significant risk, it's easier. I think with these fluids, some of them, it's easier theoretical, but I think when it has happened, for example, if you look at being exposed to a sputum, people they become, a bit worried. And it's all about reassuring the person who's exposed. And, at any given suspicion that whatever fluid that is was blood stained, then you should be considering to give appropriate PEP. So the package of care that should be offered after exposure. So you need to assess whether a person is eligible for the relevant post-exposure prophylaxis. Hepatitis B and C testing needs to be done, and there must be a consideration for hepatitis B prophylaxis. We also want to prevent pregnancies. We want to prevent STIs. And then you can also discuss beyond the emergency contraception, just general contraception advice. Remember, there might be a need for compensation if this is a occupational exposure. So make sure that documentation is done correctly and referrals to relevant departments or even occupational health for documentation, is done correctly. Emotional support is huge, So we have to provide support, counseling, and then also monitoring and management of side effects of medication, because they are going to be with you for the next few weeks. So you need to educate them about possible side effects and what to do should these side effects become a reality. So this was just to say, once someone presents and they have been exposed, what are some of the considerations that you need to do? So in your history taking, you're also taking history to try to look at this exposure, how big is it, how risky, is it, should you consider other prophylaxis therapies beyond just HIV, etc. Right? So Dimpo, I think this part we have dealt with it. So it's still the same question. So just to say that we may discuss referring the patient to another clinic or hospital. So it depends on where you operate, right? So once you have taken care of the immediate needs of the patient, remember this is still a medical legal case, in a way. And some patients, and especially with Dimpo, and I suspect it might be a close family member or a relative, she might not even be sure whether she wants to open a case or not, so you would have to engage with her around that, but give the immediate care. And then if you cannot offer forensic medicine, or you don't have a kit, whatever the challenges are, ensure that she gets that kind of support, as soon as possible. At the very minimum, assess and discuss her safety, because we don't know who this person is. Look at prevention, of STIs, prevention of pregnancy, ask also about her own support, her partner, and then offer post-exposure prophylaxis and any other support that would be required at that point in time. So this is quite important, right? And then in terms of reporting sexual assault cases, remember all sexual assault victims, you are going to encourage her to report, but it's an option, right? At the end of the day, she still has to take the decision whether this is something she wants to report or not. But our recommendation as health workers is to recommend that this should be reported, right? However, as a health worker, you have a legal obligation to report sexual offenses only if the victim, right, an older person who cannot care for themselves, so the Older Persons Act covers that, a minor, so anyone who's regarded as a child as per the Act, but also a person who is mentally ill as per the Mental Health Act. So these are people who then need proxies or who cannot take care of themselves. So as a health worker, if you classify, let's say, Dimpo as either of these three, now you as a health worker, you would have the obligation to report this particular case. So this is quite important as well. So I hope you understand this part. So continuing with Dimpo, what are the steps to be taken? Do you have an idea to say when someone presents to you with a sexual assault case, before you even consider PEP, what are some of the Renee says mandatory reporting changed recently. Vulnerable persons, also female students in is that higher education up to the age of 25. Renee, can I give you talking rights so that you can maybe comment on that again? I think you still have talking rights, Renee. Can you maybe share with us this particular update? Thanks.
Oh, colleagues, this is a bit of a sticky one, because the three new GBV Amendment Acts came into basically into implementation at the end of July, so the 1st of August this year. And it's difficult for the doctor-patient confidentiality clause for students who are in higher education or anybody in vocational training up under the age of 25. So this extends our mandatory reporting duties. And it's difficult, because somebody's a 24-year-old student, and she has complete capacity to decide whether she wants to report the case to the police. She would prefer not to. And then, as healthcare workers, we have to say, well, we have a legal obligation to report this to a police officer. And that would involve sort of FCS or, your local detectives to come in. But on this note, as from my experience, I would always say to this patient, I have a duty to report it. The police will register an inquiry, but you don't have to engage with them. If you don't want to give them any information, that, it's your prerogative. You can change your mind at any time. Maybe let's get the evidence collected, but, we can't force somebody to give the information to the police. So it's a difficult one, colleagues, but something that we need to be aware of because there's legal implications for us. So I just wanted to mention that. Thank you for the opportunity. Thank you.
Thank you. Thank you again, Renee. That is quite empowering. And this would always be ethical dilemmas, competing, the law versus our own codes within the health profession. But yeah, thank you for that particular update. I saw Tebogo Tsebe, I don't know if you still want to raise your hand, you let me know. But yeah, so let's then poll this particular question and look at it differently. Do you know which baseline tests should be done as part of your preparation to offer post-exposure prophylaxis within this context? Okay, 15 more seconds. Tandega, you are saying HIV, hepatitis B, creatinine, RPR. So there's 4. Which one? What about pregnancy test? Tandega? Yeah. All right. All right. I see Catherine. I see. All right. Superb. All right. It's 30 seconds. I'm going to stop there and look at it. Mr. Mutwaling, any test that we should not do? I have a feeling that all these tests are indicated. What's your take?
The tests that are very important would be obviously your HIV, your hepatitis B, pregnancy test, depending on what regimen that the person will be taking. You might want to do creatinine as well.
Sure.
So, but in terms of HIV, I just want to, before you get into it, to also emphasize that it's important to take rapid test rather than your ELISA. As we know that both tests are antibody tests, and ELISA is a bit expensive, and the results might not even come the same day. And you're also looking at giving this person PEP within 72 hours. So it's very important to know that one. Thank you, over.
Thank you. All right, colleagues, let's then look at it. And so remember, we spoke about why it's important to give first aid. I mean, first aid, all it means is that there's always the immediate care that needs to be provided. You need to assess the mechanism of exposure. Also, if there are wounds, you would need to examine those wounds. You need to assess eligibility for PEP based on how the person is exposed, existing medical conditions, very important. The immunity status determines other additional post-exposure prophylaxis therapies. Pregnancy status, particularly around women of childbearing potential, but also the time since exposure, very important for most of our post-exposure prophylaxis therapies. Janine, Josias, you are saying, legally speaking, the word sexual assault excludes sexual penetration, which is rape. Sexual assault means non-penetrating sexual offenses like fondling, groping, etc. best use the word sexual offense. Yeah, this covers sexual assault and sexual penetration amongst others. I think we're gonna have a follow-up session and we need to get some legal people and also experts in the field. But thank you for that, Janine. I think it's quite an empowering comment. Colleagues, you may comment, or you only send it to the host and panelists. Janine, maybe send it to everyone so that the colleagues can also engage on it. And here are your tests. So an HIV test must be done, and preferably a rapid test. So preferably a rapid test. Hepatitis B surface antigen must be done. So remember here we're looking at the source. If we do have the suspect or the source source or suspect, right? It depends on the case. But in our scenario, we're talking about a sexual offense, which is what Jadid says others get used to use. Learning as well. Hepatitis C, we want to check that. Pregnancy test, syphilis as well. And then the choice between creatinine and an FBC, depending on what your HIV prophylaxis would be. Obviously, our first line would be a tenofovir-based option. So most likely you will start with a creatinine and then hopefully, take it from there if it comes back abnormal. All right, so HIV test, actually all the tests that were listed should be done as part of your baseline, which is quite key, right? So here are the results. Limpo has a negative pregnancy test. She agrees to HIV screening, and the HIV test is also negative. There are no symptoms suggestive of STI. Her physical exam has no signs other than evidence of trauma. So there are physical signs of trauma that you would have noted. And as part of your management, you have to provide that immediate care depending on the type of trauma, if there are wounds, and it's always good to also take pictures as well, if you have consent from the client, because these can be quite useful beyond the J88 when maybe we get to the legal system later on. Now, here's a question again for you with regards to the different prophylaxis therapies, and we start with the STI prophylaxis. Which of these antibiotics would you, and it's probably a combination, so Tadeka, where did you type that one? It's like you knew that the question would come. Thanks, Tadeka. That's good. Janine as well, that was too quick, unless if you are a good typing person. Galaxy, I can't see your name. Yeah, okay. Good. Yeah, so let's familiarize. It's very important to familiarize ourselves with the new guidelines. They are no longer new, but remember, the STI prophylaxis always follows, resistance profiles in the country. There's always surveillance that happens, and we know the resistance profiles, then it is determined. Mr. Muthaling, we're happy more is what do you think of these results? Are they reflective of the guidelines?
Yes, when you look at the STI guidelines, this is relevant to those guidelines. Cool. Where we'll be giving ceftriaxone, IM, azithromycin orally, and flagyl as well. So those are the three drugs that are supposed to be given according to the guidelines.
Superb. So yeah, ciprofloxacin in South Africa no longer used, cefixime no longer used, doxycycline clearly no longer used in the STI program. So a combination of azithromycin, ceftriaxone, and metronidazole is what we use either for prophylaxis or for even treating STIs in the country. And that is your dosages as per the STI guidelines 2017 to 2022. I hope you have that guideline, otherwise I'll have to share it later. So ceftriaxone, 250 milligrams, IMI stat, azithromycin, 1 gram, and metronidazole, 2 grams. Where there's a penicillin allergy, you might want to increase your dosage for azithromycin to at least 2 grams, and so on. So that is how you would handle it, right? We move on. What about emergency contraception? What do we use? Let's see. Yes, Franz, noted. I will create a nice email with hey, Janine, are you working in the private sector? I see you are using the beautiful names there. Maria, Levo, all right, cool. Renee, yeah, all right. Yeah, but what are your options there? And I still see the old option. It is always coming through. And I tell you, our current guidelines have changed around that particular drug. So maybe let me move on and show you where we are. Let me see. I just want to check if I'm still on track with regards to time. So yeah, you are looking at your results there. I can tell you that overall is what I used to use as an intern or ComServe and later on. But in the last few years, it is really discouraged because most women are not coping with that. There's a lot of side effects and therefore its effectiveness is significantly reduced. Levonorgestrel, important. It's interesting that copper IUD, one of the most effective emergency contraception options. And with regards to long-term, contraception, is probably something that we should try and recommend more. But maybe for the poor, not now, though it can still be used. And I want you to know that a copper IUD is one of the most recommended options, at least in the country. Maybe for the poor, not necessarily, an ideal one. So just remember that unprotected intercourse includes, when protection methods fail, situations when a method was used incorrectly or where the contraceptions were not used at all. So you need to be able to classify your patients correctly so that you don't limit access. Emergency contraception tablets should be taken as soon as possible, no later than 5 days. So remember, for HIV, PEP, we talk about 72 hours. For contraception, we talk about 5 days. And it can be taken anytime during the menstrual cycle. There's all sorts of beliefs, but to be honest, emergency contraception can be given anytime and should be offered to all women who had unprotected intercourse, as per the definition above, especially those who are currently not on any form of contraception. The two main recommended emergency contraception in our guidelines currently, it's your emergency contraception, particularly with the levonorgestrel, which I'll discuss now, and a copper IUD inserted up to 100. So all of them you need to insert, within 5 days from the particular exposure. So the recommended regimen is levonorgestrel 1.5 milligrams as a state dose. It's important to also provide an antiemetic because nausea and vomiting is a common side effect. If vomiting occurs within 2 hours of taking the emergency drug, another dose should be taken. Alternate regimens include combined pills, including levonorgestrel or even ethinyl estradiol, in various ways. But really, by all means, levonorgestrel 1.5 as a state dose seems to be something that we all have. The use of overall is no longer recommended except in exceptional circumstances. And this statement, I've copied it directly from the guidelines. So it's quite important. And yes, Renee, we must be careful if patients are taking, liver enzyme inducers like rifampicin and some of the ARVs as well. So we need to be very, very careful. Also, if you are dealing with someone who is a bit obese, you might need to provide twice the dose. So just remember those kind of things. And I think that was my next slide, Renee. Thanks for that. So be careful of enzyme inducers, right? But also people who have a high BMI where you might need to give twice the standard dose, right? And if routine contraceptive is used, is well established, it is best to continue whatever your patient is using, right? And remember that emergency contraception is not 100% effective. So you need to also do a repeat pregnancy test in your follow-up visits, which is quite important, right? Yes, Lungile, we will share the slides. Thanks for that. Yeah, so as we continue with the different prophylaxis therapies, we are now looking at the HIV prophylaxis, because sometimes when you say PEP, people are just thinking HIV, you know. So Jadid, where did you type? Jadid, do you have my slides? Nice. TLD. All right. Don't clap, God. You guys have my slides. That's nice. Yeah, maybe let me give, because I'm sharing my slides with Mr. Mutwaling. We have moved, guys, from too many tablets to a simple regimen. Mr. Mutwaling, would you like to comment on that? Yeah.
Yeah, thank you, Dr. Mawela. Yeah, we have moved from many regimens that we were using before. So currently, with the approval of DTG use in South Africa, so we are having only 3 drugs regimen, which is your tenofovir, lamivudine, and DTG. Sorry.
Yes.
Yeah, those are the only drugs that you are providing at the moment for adults and adolescents.
Superb. Colleagues, remember, for me, when I had a little prick trying to draw blood from a baby who was very restless and fighting, and actually I was helping a nurse, and then the baby kicked the needle. I can't remember, it ended up on my hand. I had to take zidovudine, lamivudine, lopinavir. I don't know, I had to write myself a prescription because I was working in the HIV space. So I knew that time that I could write myself a better regimen. I literally wrote it myself and stopped this lopinavir thing. I couldn't cope. As they say, as health workers, we experience the worst side effect for one reason or the other. So TLD, tenofovir, lamivudine, and DTG, but you need to be able to assess which patients are eligible and which patients are not. So firstly, the HIV status of the source person really is quite helpful. It can minimize, the use of the use of ARVs unnecessarily. So if the source patient's HIV status is negative, and because I work in the HIV field, for me, a negative test is worrisome. You have to assess also the risk that they could have contracted HIV the last few weeks. But anyway, if you have confidence that the source patient is negative, there's generally no need, I think, for PEP, as you can see. And the high-risk exposures, really, percutaneous exposure, like your needles and then splashes in your eyes, mouth, and other areas would be regarded, as the 2 key ones where a regimen must be used. And also there's a subtle change. Remember the old guidelines, you could use 2 drugs for a low-risk injury and then 3 drugs for a high-risk injury. That low-risk, high-risk issue is no longer part of the guidelines. We are just assessing, was there significant exposure or not? If there was, and the source patient status is unknown or positive, all patients receive a 3-drug regimen. There's no longer a place for a 2-drug regimen, right? And then if the exposure was through non-infectious materials, there's no need for PEP, irrespective of the status of the source patient. If there was exposure to the skin, but the skin of the person who's exposed is intact, right? No wounds or cuts or things like that, really, there's no indication for PEP. But the issue of risk, you have to assess it case by case based on the history and what actually happened with regards to the incidents and other issues around your source person, as we look at it there. So that is quite important. And Misha, you are saying exactly, a negative test is not always reassuring. Yes, that's why you must take history from the source around the risk of acquiring HIV, because one single negative test could still, could still be regarded, as someone who's high risk for seroconverting. So, I mean, we are getting into a very complex thing, but to keep it simple, a negative test generally does not require PEP. You're asking about human bite. Yes, remember we discussed other inadvertent exposures, and a human bite was one of them. So if there's a human bite, you also need to consider other prophylaxis therapies as well. So for ARVs, this is now the standard. We've got one regimen for adults, as long as they are older than 10 years and their weight is above 35 kgs, you should be able to use tenofovir, lamivudine, and dolutegravir for 28 days as a fixed dose combinations, right? So generally, tenofovir and zidovudine are recommended. So that means where TDF cannot be used, maybe there's renal impairment, you could use zidovudine. Abacavir is not recommended due to risk of hypersensitivity. But I tell you, where you have run out of options because of complications or other conditions that your patient has, you have to give some form of PEP, and you might need to contact the call centers or people who are experts in the field. Lopinavir, like I said, lots of side effects. It's still there if there's absolute contraindications, to DTG. If your patient is also taking TB treatment, remember to increase your DTG dose to 50 milligrams twice a day. Atazanavir, a bit better in terms of side effects compared to lopinavir, but there's that asymptomatic, hyperbilirubinemia that you might have to deal with. Generally, efavirenz and nevirapine, to be honest, this is a place where we don't want to go unless if you have ran out of all options in the space. All right. So I hope this is quite helpful, and important notes, right? I didn't put them by chance. If the source patient is on third-line ART and has confirmed resistance to protease inhibitor DTG, consult. So if you are talking about being exposed to blood products from a patient whose treatment experienced and they have history of failing regimens, it means some of these drugs might not be effective in preventing transmission for these groups of patients, which is quite important. These are some of the side effects, tenofovir, check kidneys, lamivudine, no issue. DTG, really, the issue is insomnia. They can take it in the morning or even headaches sometimes. Emtricitabine, no issue. Zidovudine, generally the anemia is an issue. Atazanavir, some jaundice, and lopinavir, ritonavir, the vomiting and this watery diarrhea. Ooh, is such a big issue. But inform your patients and also prepare them for this particular issue. Right, so you can see that PEP is not about HIV. There's a whole lot of prophylaxis therapies that you need to really consider for your client. Now, with regards to hepatitis B prophylaxis, I'm not sure if I had a question about this one. All right, yeah, I have a small question for you. There we go. So I wonder how much you know about the prophylaxis here. Would you give the vaccine? Would you give the immunoglobulin, or would you give both? We don't have a lot of information actually to decide. I wonder how you are deciding to answer. All right, give the vaccine and do hepatitis studies, both, Carl. Rene, immunoglobulin, very scarce. Both, Keisha, all right. Brian, you're talking tenofovir, emtricitabine. Okay. So let's then look at what the guidelines are saying. These are your results. Yeah, you are competing. So there is not, we don't have an obvious winner there. It's like a marathon. All right. Let's then look at it slowly. So hepatitis B exposure may occur, outside of other situations. So remember, we are also an endemic country, by all means. So it's quite important that you at least try to check your source patient, and also people who have wounds, especially human bites, you might needle sharing, you might need to check. PEP recommendations are the same, irrespective of how the exposure actually happened. Hepatitis B transmission risk, if exposed, is very high. Remember, 30%. This is very significant. probably is the most likely infection we are likely to get after being exposed compared to HIV. Previous hepatitis B vaccination should be assessed. Actually, it informs also what type of prophylaxis you are going to offer. And remember that hepatitis B immunoglobulin protects by passive immunization. So this is not long-term. It sort of covers, it gives that protection at least until the vaccine is able, to induce immunity at the right time. So they are best, used together. So when is it indicated? Following exposure to blood products, especially if the exposed individual does not have protective hepatitis B surface. So if your antibodies are not more than 10 units, then you do not have, enough protection. And then also if the hepatitis B antibody status is unknown. So remember, if it is unknown, we are not going to wait for the result. We have to at least do not try to delay, try to provide the intervention as soon as possible, right? So if you cannot get the results of your surface antibodies within 24 hours, you have to provide the intervention. There is no need for investigation or therapeutic intervention if the exposed person, has the infection, if you are fully vaccinated and we know that you are immune, right? Or if the source is hepatitis, does not have hepatitis B, basically. So we don't have, to worry that much. So here's the, I thought that's the next slide. There's a nice graphic picture, which I will show you now. So basically your immunoglobulins have to be given as soon as possible, preferably within 24 hours, as soon as possible. Don't wait for 3 days, it's too far. HBV PEP is unlikely to be effective if given after 7 days for perinatal or needle stick exposures, or over 14 days for sexual exposure. This is very important. So for our case, if she presented day 5, day 6, we could still, give it. But really for perinatal or needle stick injuries, it must be given as soon as possible, ideally within 7 days. Now, these timelines are very, 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 very important. I want to summarize it. Yes, this is the table I've been waiting for, to say when you have to decide about hepatitis B PEP, you have to assess the source, right? Very important. Hepatitis B status of the source. Obviously, if the source is negative, we are not too worried. But if the source is positive or the status is unknown, we are worried. But also we are looking at the person who is exposed. So if you're looking at Dr. Mawela and Dr. Mawela is exposed but vaccinated, and you have evidence that my HB surface antibodies are more than 10 units, you can see generally, irrespective of what the source has, because I'm immune, there is no need for any form of treatment. Where you are going to treat particularly, it's where the source status is unknown, the source is known to have hepatitis B, and the exposed person, maybe Dr. Mawela is not vaccinated, Dr. Mawela is not sure, I only got 1 dose of the vaccine rather than the 3, or I'm vaccinated, but my immunity is very low or unknown, the red part there. Then I need to get the intervention. And what is the intervention? Is dual. You provide hepatitis B immunoglobulins, IMI, 500 units, right? And then you also start at least the first dose of vaccine, and the other 2 doses will be received the next 2 consecutive months, which is quite important, right? There's other things I wanted to, let me see if there's anything. So this first bullet, very important. Remember, your immunoglobulins and the vaccine can be started same time, but should not be given on the same site. So that they must be given on the different sites. And then if your facility does not have the immunoglobulin, just provide the vaccine and refer your patient for the immunoglobulins, which is quite, and Janine, maybe this answers your question, to say at least give the vaccine and then refer for the immunoglobulin, right? If there's a delay in obtaining hepatitis surface antibody, that means you cannot confirm whether Dr. Mawela is immune or not. It is best then to provide the vaccine, and maybe treat as if the person is not immune, because we don't want to delay waiting, which is quite important, right? So very, 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 very important. Hepatitis C, unfortunately, there is currently no vaccine for hepatitis C. So if the source is known to be hepatitis C negative, the exposed person does not have to be followed up. So at least there we are at peace. However, if the source patient is known to be hepatitis C positive or the status is unknown, like in this instance of Limpopo, the exposed person should at least be tested for hepatitis C antibodies at baseline and a PCR 6 weeks post-exposure, right? There is no effective vaccine or immunoglobulin available for the prevention of hepatitis C, which is quite unfortunate in today's day, you know, and where we are. All right, great stuff, colleagues. I hope you realize that we are nearing the end. This is probably the last prophylaxis question I'm asking. Let me check the time. Mr. Mutwadik, I think we will have little time for questions. Let me try just fast track from here. So what will you give for tetanus, right? So tetanus is quite important as well. So tetanus is a fatal infectious disease. It is a bacteria. If there's an open wound cut, you know, you have to consider tetanus. If we do not provide appropriate prophylaxis, your patient might present with painful spasms, you know, and leading up to death. So it's important to prevent tetanus from happening, and regular boosters as well are necessary to ensure immunity. There's one question you should always ask. You know, firstly, remember Dimpo, we said she's got physical injuries. If there's open wounds and stuff, we don't know, you know, whether she was in contact with the soil, this is a soiled wound or what. But the immunization status is very important. So you need to ask, in the last 5 years, have you ever received immunization against tetanus, right? If the answer, if the person, yes, has been immunized, you can see there's nothing. So if someone is immunized in the last 5 years, you don't need to intervene. But if they have not been immunized in the last 5 years, and it's a clean or minor wound, you know, you can just give the tetanus toxoid, right? However, if it's a human bite, it's a dirty wound, you know, or a high-risk wound, and you can see here such a wound, but not limited to, contaminated with dead feces, soil, saliva, puncture wounds, avulsions, wounds resulting from missiles like a gun, crushing, burns, frostbite. All these wounds, your patient would need to get two things: your tetanus immunoglobulins and your tetanus toxoid, IMI 0.5 mil. So please don't forget. Yeah, Jadid, not always available. We know the challenges with these issues, but at least you know what needs to be done. So maybe refer, call, and let's see, maybe, you know, ask the patient if they can be able to buy, because tetanus is a very fatal condition. This is just a summary. So when I share the slides, you know, tomorrow, this is a summary to say, in terms of the different prophylaxis therapies, depending on the type of exposure, which ones must be given. And you can see today we used a sexual exposure case study. So HIV prophylaxis, HBV prophylaxis, emergency contraception, STI, tetanus, you know, only if it was a pure sexual exposure, there are no physical injuries, there are no open wounds, you might not give tetanus. But if it's a sexual exposure and there's injuries, you would also probably consider giving tetanus, right? And you see human bites would also require HBV prophylaxis. So luckily there's a nice summary of all the 4 or 5 prophylaxis therapies and when to give them and when not to give them, which is quite important, right? And what is your follow-up plan? So how do we follow up our patients? Remember, side effects, adherence is very important. Manage anxiety, provide support, you know, risk reduction counseling is very, very, very important. Don't make people to get PEP, you know, now and then. It means you are not managing behavioral change, you know, correctly. Depending on the type of exposure, provide relevant follow-up laboratory tests. If your client tests positive for any condition, make sure that they are treated. Emphasize the importance of coming back for follow-up because the status does change. So if for HIV, remember we do it at baseline, but 6 weeks we must repeat. And again, Oh, my slides are not moving, Jenny. Is that everyone, or is it Jenny only? Please check on the chat there and let me know. 4 months, again, we must repeat the rapid test. Hepatitis B, we do it at baseline and again at 4 months, which is key. Hepatitis C at baseline and again at 6 weeks, which is important. Syphilis, we do it at baseline and again at 4 months. You can take a snapshot of this slide. Creatinine at baseline and again 2 weeks if you have started TDF, again FBC or HB at baseline, and then again 2 weeks after starting PrEP. Pregnancy at baseline and again at 6 weeks. So you can see that it's a table that is nice to have in your facility there, because it would really help you. This is the last question to say with regards to sexual assault cases. Are there any other specific needs that you think the DIMPO might need? And it says here, all persons subjected to sexual assault offenses, to correct myself, including members of the LGBTQ community and persons with disabilities, should receive PEP. And as I read this statement, it reminds me that it means sometimes we are discriminatory against certain populations, who may present with sexual offenses. So let us not be part of people who are discriminating, but if someone presents with a medical condition, irrespective of who they are and what they believe in, we should be able to care for them. Remember, your immediate care is very important. So if they've been hurt, if they are bleeding, we have to deal with those issues. Remember also psychological safety, so that they feel free, open, really to communicate. Emergency contraception, make sure that forensic specimens are collected. Sometimes even if she's not sure whether she will open the case, at least collect the specimens, because if she changes her mind in a week's time, then you can decide, to submit. Prophylaxis for STIs, psychological interventions and support, referral and multidisciplinary support. Provide counseling and support, taking PEP, testing for HIV, follow-up appointments, and emotional support. And don't forget the prescription. I think the key issue about the prescription is this starter pack issue. The guidelines no longer recommend that you give people a starter pack for like 2 days and you ask them to come back. No, it must be a full 28 days course, because starter packs have been associated with interruptions in the supply of PEP with really bad outcomes. All right, I've tried to push, but I hope that we have managed to cover most of the things that I wanted us to cover. Maybe at this point, as I take a sip of water, let me ask Mr. Motwaleng if there's any comments around the presentation and key take-home points, and then we take it from there. Thanks.
Yes, okay, Dr. Mawela, and thank you for the opportunity once more. I just want to, in addition, that something that I think we might have forgotten to mention is the regimen for children. I think we focused only on adults and adolescents. Yes. Yeah, but it's something that you can, always add when you share the presentation. Yeah, but overall, everything that we needed to any information that we needed to distribute out there, I think we have covered everything. But also, I just want to add that, in terms of the people who are at risk and who might not be sexually assaulted, we might also want to encourage them for a PrEP transition, So more often than not, we find that the person would come and use PEP as part of prevention more than once, more than twice. So in such cases, you might want to engage the person during the risk assessment and counseling, and see if the person cannot be transitioned to PrEP usage, as part of the HIV prevention package. So yeah, so I think we've said a mouthful, and we've covered everything that we wanted to say. So thank you very much, Dr. Mawela, for the information, and thank you to the participants as well. And we also have learned a lot from the chats, what people have been writing on the chats. So this is something that you can also learn from everyone. Thank you very much, and over.